Ve şimdi Sharon Zarabi sırası. Kendisi 2005 yılında New York Üniversitesi'nden mezun olup Long Island Üniversitesi'nde uzmanlığını tamamlamış birisi. Ve 13 yıldır Dr. Rosalind'le beraber bariatrik cerrahi üzerine Amerika'da çok güçlü, kuvvetli ve güzel çalışmalar yapmakta. Bugün bizim onur konuğumuz. Ameliyat öncesi ve sonrası beslenmesi ve geri kilo alan hastalara bu konuya yönelik nasıl yaklaşılması gerektiğine dair güzel bir sunum yapacak bizim için.
Thank you all for being here. Esri for Barry Fit, Selma for coordinating this within 14 days. We put this whole thing together. And Dr. Mehmet Yurdel, it's Ali. It's a pleasure for me to be here and speaking with you guys all and talking about my experience in bariatric surgery. As Merve introduced, I've been doing bariatric surgery for 13 years in New York City, and I'm very blessed to work with very world-renowned surgeons who do a lot of different types of surgeries. Today's focus will be on the gastric sleeve, on the vertical sleeve gastrectomy, so I hope that it will be resourceful for you. So I have a question for some of you. How many of you guys are bariatric dietitians? And how many of you are just registered dietitians interested in learning about bariatric surgery? All right, so I'm going to talk a little bit about how we work in our center in New York City. We are a very large volume facility. We do about 650 bariatric cases a year. We have 4 surgeons in our office and only 1.5 dietitians. So it's very, very busy. We have a lot of people coming in. Surgery is a very important decision. We operate on patients who have a BMI of 35 or higher with one comorbid condition. Or BMI of 40 or over, and in America, insurance in New York specifically. So the first step in our program, the patients, I'm a huge advocate for education. We have a very comprehensive program in New York at Lenox Hill Hospital. And the first step for the patients of participating in our program is they need to attend a live seminar. So we have a surgeon who talks about just exactly what Dr. Yurdel presented, all the different types of surgery, what is obesity, how is it caused, and how bariatric surgery assists with treating and curing obesity. And after they attend the seminar, they then meet with the surgeon and they have an initial consult to speak about their past medical history and which surgery would be best for them. They meet with me. So it's very intimidating sometimes for someone who is of larger size to meet with a dietitian. I'm usually the last person they want to talk to because they may not feel comfortable speaking about food with a dietitian. So in our clinic, what we first do is instead of meeting with me face-to-face, we sit in a nutrition class. And so when they meet with us in the nutrition class, there's other patients, so it makes it a little bit more of an open forum. They feel more comfortable. And I don't even speak food the first time we meet. I speak about wellness. I speak about well-being, because this is a key word. If these 6 pillars aren't in balance, then this surgery will not work. So they're coming in, if you see here, you have physical health, you have intellectual health, psychological, emotional health, social, spiritual, and occupational. The patients come in thinking that I'm here for my physical well-being. I just want to lose weight. That's it. When I lose weight, I'm going to be happy. When I lose weight, everything in my life, my relationships with people is going to change. But what we're here to really show them that physical, mental, social, all of these need to be working together. If they don't have a good relationship with their friends or their coworkers, if they go to work and they're always angry, if they're working 14 hours a day and sleeping only 4 hours a day, if they're depressed, If they, intellectually, they're not learning new things, professional development, personal development, if they don't know how to read a food label, all of these are going to affect their success rates and their outcomes of surgery. And so when they come into the nutrition class and we speak about wellness, we need to also figure out what brought them here. Why are they here to have weight loss surgery? What type of eater are they? Do they skip meals? Do they not know what protein, fiber, fats, carbohydrates are? Are they not sleeping enough? Do they just love to eat? So these are the things that we want to learn from the patient, and then we conduct a nutrition class based on their knowledge. In America, we're still having this calories battle. Are we obese because we eat too many calories, and are all calories created equal? So this is a big thing we're all trying to figure out. Is 100 calories of a piece of bread the same as 100 calories of an apple? And the reason why we explain this is because what the surgery does, the gastric sleeve is to cause restriction so the patient can eat less calories. But now we need to talk to them about eating different calories for their future. Because 2,000 calories of a westernized, highly processed, based on carbohydrate diet is not going to be the same as 2,000 calories of a Mediterranean diet that has more protein, more fiber, and more whole foods. So we're here to teach them calories, okay? Too many calories contributes to weight gain. We need calories. We need calories for energy. We need calories to think. We need calories to move. You guys, if you didn't have breakfast today or lunch, your brain is shut down. So the information that you're getting will not be retained. So it's important for the patients to understand they need calories, but if they eat too much of the wrong ones, that's what contributes to obesity. I really want everybody to understand the concept of calories, because I think it's so important for the patients to understand what happens when they have the gastric sleeve, because a lot of them, when they sit in the nutrition class, they're already, well, I don't need to listen to this. I'll do this after surgery. We're giving all this information to them before surgery to try to get them to take the concepts and start practicing now. They are encouraged to lose weight before surgery, and not by starving themselves to shrink their liver, but to actually put some of these principles into practice. Here, so we all went to dietetic school, and we learned that for every 1 gram of carbohydrates, it contributes 4 calories. For every fat gram, we get 7 calories. Protein provides 4 calories per gram, and alcohol is obviously very caloric. The reason we go through this is because, again, to give you this concept, not all calories are created equal. And the same thing goes for after surgery. A cracker, okay, a cracker or a pretzel, and you put it on your tongue, what happens? It melts, okay? So you put a cracker on your tongue, it disintegrates, it melts. You don't need to do any work to do it. Okay, the gastric sleeve, you have 80% of your stomach removed, and now you have a stomach the size of my thumb. That's the size of the stomach after the sleeve. They could still eat crackers, no problem. Okay, the crackers melted in the mouth. They go right through the sleeve and they get stored as excess calories, empty calories. I want to try and teach them that they need to eat more whole foods, okay? Foods that take work to digest, foods that have a higher thermic effect, meaning the body uses energy to break it down. If you take chicken and you put it in your mouth, does it melt? You put an egg on your mouth, or nuts, or vegetables. We need to chew it. Crackers, pretzels, cookies, all of these processed foods do not require any chewing. They can go right through the sleeve, and with time, a patient will say, well, I had weight loss surgery. My doctor told me I'm going to be full, and that's how I'm going to lose weight. Why am I still hungry? So that's why the dietitian, the nutritionist, is such an important part of this patient's journey after surgery. We need to become food therapists. We are their life coach. We are their support group leader. Our patients are very, very good at losing weight. What's the hardest part? So the hardest part is actually keeping it off. Everybody can lose weight. So we are here to create what I call loyal eaters. They need to learn how to respect their hunger. It's okay to be hungry, okay, because they're going to be hungry after surgery. They just need to learn how to eat. So we're here to teach them, and most of you learned all of this in school, where their macronutrients are coming from. We need to teach them, this is that intellectual wellness circle that we spoke about. This is that nutrition knowledge. What are carbohydrates? Where are they found? Complex versus simple. What are fats? Where are they found? What is saturated versus unsaturated? What is protein? Where is that found? And so I also go over obviously what the function is. Protein is needed for wound healing after surgery. Protein is needed for hair, skin, and nail growth. Protein is needed to help build lean muscle mass. Protein helps the metabolism remain elevated. Carbohydrates are going to give our patients, quick energy. But when they're in an obese state, they don't need so much energy. They need to transfer their fuel to the other sources, such as more fats and more fats and more proteins. Once we give them the basic nutrition knowledge, now we can talk about nutrition. Once they understand how they got here, now we can talk about how to fix it moving forward. In the United States, we have many different types of procedures, as you guys have seen. It has evolved over time. We have mainly restrictive procedures, which just allow a smaller amount of food to be taken in by the patient. It is still possible to regain weight with any procedure if the patient does not change their behavior. With it will come some risks, okay? So that's why it's very important for the patients to understand they're not having surgery and losing 50 kilos and walking out of the hospital skinnier. There's obviously pros and cons to having the surgery. And if you see this diagram here, we show you that when you start to alter the natural anatomy, and of course this is, again, because we do more common malabsorptive procedures in the States, this just shows you where certain micronutrients, vitamins and minerals are absorbed in the digestive tract. When you have a smaller stomach, there's also less hydrochloric acid that's being produced, and hydrochloric acid actually affects intrinsic factor, which absorbs B12. So hydrochloric acid plays a major role in absorption of nutrients, and when you have 80% of the stomach removed and the greater curvature taken out, although your ghrelin hormones, which is the benefit of having surgery, you're having your ghrelin hormones, which are your hunger hormones, removed, you're also creating less acid, which is going to affect the absorption of some nutrients. Here are some common complications with some of the procedures. Again, the more malabsorptive ones are going to have higher ones. With the gastric sleeve, it's just restrictive. There might be anemic. There might be some metabolic bone disease. There might be thiamine deficiency if there's chronic vomiting, because when you have a very tight sleeve, okay, food may not go down very easily, and it's going to be coming up. So if they're vomiting frequently, they may have thiamine deficiency. They might have hair loss because they're not eating enough food. They might even get weight regain, and that's something that we see long term, and I'm going to talk about that a little bit later. We've created the American Society of Metabolic and Bariatric Surgery out in the States. And dietitians came together and we said, how are we going to standardize? What can we do for our patients to give them the most safe and effective nutritional recommendations? So in 2008, okay, we came up with the first guidelines. We just updated them in 2016. They're still very similar. And another resourceful source for me was Micronutrition for Weight Loss Surgery Patient by Jacques. And these are places, there are resources out there that help give us some knowledge on what recommendations to give for patients as supplementation. That's why it's so important that all of you are here today, and thank you again for coming. I think it's so important that we all collaborate. The ASMBS, the dietitian side, wouldn't have existed if we didn't have people like us who are active and proactive and want to learn more. I know when I sat in Dr. Yurdel's office, Fatma started a very extensive spreadsheet, and Merve is now taking over of looking at all the patients' levels of their blood work. It's so important that, if you guys are working in clinics, you're gathering this data so you can compile some recommendations and standards of what vitamins to give out, because what we have here took a lot of work on the dietitian's part through ASMBS. So thank you to Fatma for starting. She told me that she got a bariatric dietitian's unit here, and I urge you all to participate. Here you can see we've given some recommendations based on the different types of procedures that do exist out in the States. If you look at the gastric sleeve, you want to make sure that you're giving a multivitamin to the patients. As I mentioned, the stomach is very, very small, so it can't eat as much food as it used to. So now we need to supplement, we need to take extra vitamins. I am a dietitian. I don't work for any vitamin company. I am an educator. My job is to teach people how to eat to live. And basically we want them to use food as medicine and food in order to get their vitamins and their minerals and their nutrients. But in the beginning it's going to be very hard when they have a very tight stomach. So supplementation is critical for the bariatric patient. And you'll notice from this chart, this gives you some of the more common deficiencies that we see. And again, it doesn't always happen with the sleeve. I see it more in malabsorptive procedures like the duodenal switch. Who knows what you guys will be doing in another 15 years here in Turkey. But we do see vitamin D deficiencies, a little bit of A. And we see vitamin D deficiencies even pre-op, which I'm sure you do too. The fat-soluble vitamins, again, only if we're doing malabsorptive procedures. The B12 is common because of the intrinsic factor. Some patients are anemic or have iron deficiency even before surgery. So this is a nice chart that gives you some ideas of what are the symptoms of these deficiencies. The chart before is how to treat it and what to be testing for in your blood work. This is basically what your vitamin should be, what the vitamin protocol is for the surgery. If you're having a gastric sleeve, we usually recommend that the patients do 1 to 2 pills of a bariatric formulated vitamin. We also recommend that they take 500 milligrams of calcium citrate. We emphasize citrate, not carbonate, because carbonate needs stomach acid to be absorbed. Citrate is absorbed a lot easier and on an empty stomach. We recommend 1,000 micrograms of B12, okay, once a week. You don't need to take that every day. It's important that the patients start on a tablet that's chewable. We don't want to block the stoma, so it's important that the multivitamin is a chewable form for the first 3 weeks, and then after 3 weeks we recommend that they can switch to tablets or capsules. So iron and calcium need to be separated. When you find a multivitamin that has iron in it, it most probably won't have calcium, so you're going to need to take a separate calcium. But that doesn't mean take the calcium with the multivitamin. You still need to separate the multivitamin with iron 2 hours apart from the calcium supplement. Also, the body only absorbs 500 milligrams of calcium at a time. So if we're suggesting 1,000 milligrams of calcium, you want to make sure the patient is reading the labels on the vitamin capsules and taking 500 in the morning and maybe 500 in the evening, so separating those doses. They make chewable forms. Their multivitamin is formulated. I mean, I went through it. It had a good amount of the nutrients that we're looking for. Most of the time, a patient might need to take extra vitamin D, and as you can see in their vitamin, because it does contain iron, it doesn't have calcium, so the patient will need a separate calcium from. I was asked by a dietitian, how do you know what vitamin is better than the other? How do you know if this bariatric vitamin is better than another? We don't regulate supplements in the United States, and I don't think you do them here in Turkey either. So it's very hard to say what vitamin is better than another. Most of the research is either going to be funded by an industry. So you need to work with the patient very closely and have these conversations with them and see, what are you eating? What vitamins are you taking? Are you taking them every day? Are you taking iron and calcium together? Because many times I've actually seen the blood work not go up, actually even decrease, because they're combining the vitamins together. So it's so important that you have this dialogue with the patient. The vitamins that we monitor over time, you can see we're looking at their hemoglobin A1C. We see significant improvements with patients who have diabetes with their hemoglobin A1C decreasing over time, obviously because they're not eating a lot of carbohydrates. We check their prealbumin, we check their triglycerides, we look at zinc. We get a complete comprehensive metabolic panel. We're checking their thiamine, folic acid, total cholesterol, their protein stores from albumin and prealbumin. hemoglobin, hematocrit, their LDLs, cholesterol levels, vitamin D, vitamin A. And one thing that I also want to note, we also have to think outside the box as dietitians. If you see something low, that doesn't mean just go and take a vitamin. You need to look at everything together. A lot of the times, vitamin A and protein, in order for vitamin A to be absorbed, you need to have high protein stores. So if I have a patient whose vitamin A levels are low, I'm going to first ask them, how much protein are you eating? Even though vitamin A is not found in most protein sources, we need to really play detective and understand how many different things are cofactors for others. When looking at these numbers and seeing any deficiencies, I always also like to get a diet recall and understand again, and I'm talking more in the long term when the patient's on a more normal diet, maybe 6 months out or 1 year out, what are you eating? Because if they're not getting enough fruits and vegetables in their diet, a lot of these numbers will be skewed. It's important to get these lab values preoperatively because a lot of the times you'll see that patients have deficiencies that aren't surgery related. So it's important to look at those numbers and replete them, okay? If they're deficient in something, you need to get them at normal values first through diet, and if diet doesn't work, through supplements, and then, go through the surgery. We're going to fast forward. So we spoke a little bit about what they should be eating before surgery. It's really a plant-based, high-protein, whole foods diet. Once they have the surgery, I want to talk a little bit about what the immediate diet is like. Some centers might actually have the patients on a full liquid diet before surgery to shrink the liver. Different institutions have different protocols. I work with 4 surgeons, so they all have different ideas. One of my surgeons has the patient on the full liquid diet, so mostly only protein shakes for 2 weeks. And then my other surgeons just really have the patients work with the dietitian on a monthly basis to try and get them to be more mindful eaters to help them lose weight. So now the patient had the surgery, They're in the hospital. They've had, again, about 80% of their stomach removed. They have this long, narrow tube, and there's staples. So we need to give the stomach time to heal. And that's why we have them progress on a specific diet. For the first day, so this is post-op day 1, the patient is on clear liquids. This is my protocol at Lenox Hill Hospital. Most centers in New York operate the same way. We give our patients water, decaf tea, or sugar-free beverages and sugar-free Jell-O. We do not allow our patients to have any sugar after surgery. However, there are some centers who do give a little bit of juice after, if it's diluted. I guess it helps a little bit with the nausea. So this is really based on your center's recommendations. I think sugar-free is fine with our patients. 2 weeks from day 2 to day 14, we have them on full liquid. So this is going to be mostly protein supplements, protein shakes. As I mentioned, we try to keep a very low sugar diet because, as the analogy we gave before, sugar dissolves in the mouth. It actually increases your appetite stimulating hormones, so we want to keep them on a low sugar diet. So any protein shake that they're getting should be less than 10 grams of sugar. BariFit, again, another wonderful post-op plan, has puddings, has shakes, has soups, all that are fortified with some fiber, with protein. And as most of you know, protein and fiber are what keep you full. When you take protein and you take fiber and you put them together, they create a gel in the digestive tract. A gel goes down very slowly through the digestive system compared to water. Water just goes through, a gel slides. We are always trying to give that patient a sense of creating a gel in their stomach. So we really want to push from forever protein and fiber, protein and fiber. I say this out loud in my nutrition class 3 times, and I make them repeat it back to me so they learn what nutrients do they want to enhance in their diet, protein and fiber. My surgeon, he is okay with the patients doing something that's very pasty by day 6. So one thing that I found here while I was in Turkey that I fell in love with was muhammara. Am I saying it correctly? So that actually has fat and protein and fiber in it. The chopped walnuts, if they eat just a tablespoon of that, that can actually help them with their hunger. Although many patients will say, I'm not hungry after surgery, we need to teach them how to eat. Something in the morning, something in the afternoon, and something at dinner. Even if they're not hungry, we are trying to use this time of recovery post-op to retrain them. Once they're finished with phase 2, okay, they should usually meet with the dietitian. This is when they come back to see me. And if everything is going down and they're not having any problems, they can progress to week 3. It's very important when they're drinking the protein shakes, they drink it slow, no gulping, because if they swallow a lot of air, it will hurt them in the chest, it will hurt them in the throat. So we tell them to do warm liquids during this phase. If everything is A-okay, we move on to week 3, and that's going to be foods that roll off the back of a spoon. So think of like a pureed blended tuna fish, a soft scrambled egg, chopped liver, pate, cottage cheese, pureed beans. All of these are protein sources. Notice you don't see fruit marmalade or applesauce, because I don't want the patient to get used to having carbohydrates during this phase. We're really focusing on protein. Their stomach is very small, they get full very quickly. We need to get as much protein as we can. Sometimes my patients say that they're constipated, okay? They're not going to the bathroom. This is my little secret remedy. They can take laxatives, but again, we're using food as medicine. This just has spinach, blueberries, chia seeds, hemp seeds, flax seeds, walnuts, Greek yogurt. This is nature's medicine right here. And if they put this in a blender, they can use this during their full liquid phase. And we're emphasizing protein. This is going to help the patients heal quicker. So remember, we're going back to the first thing we taught you, not all calories are created equal. We want these patients to really focus on their protein. And how do we recommend that? Well, again, because bariatric surgery is still one that's evolving, we've taken the recommendations for anyone who is on a medically supervised protein fast. So we use the 1.1 to 1.2 grams per kilogram as the recommendation. This can average out to about 60 to 80 grams of protein a day. But keep in mind, if the patient just had surgery and their stomach is still very, very small and it's inflamed and it's healing, they might not get 60 grams. So every day I would get a phone call, Sharon, my handbook says I need 60 grams of protein, but I can only get 30 grams on the first week. That's fine. We want them to achieve 60 to 80 grams, but even in the beginning weeks, as long as what they're focusing on is protein, then we're good. Since there's less stomach acid, the stomach is not working as well. It's not functioning optimally to help digestion. So chewing your food after surgery is one of the most important things that we need to teach our patients. A lot of our patients who are overweight, they eat very, very fast. They just put the food in their mouth and they swallow. They don't use their teeth to grind it. It's very important that they use this time, their post-op phase, again, as their training mode and chewing the protein very well for it to be digested. Some of the short-term post-op difficulties that occur, some patients may not like the same food, so they may be intolerant to some foods. If you think about what happens when you put bread in soup or you put bread in water, what happens to it? Anyone who can answer that? Bread in soup, what happens to the bread? It expands, it swells. So you remember you have this small hole for food to be going through and a long tube, so there's no space for food to expand in. Foods that expand upon cooking, pasta, rice, bread, spongy foods are going to be very difficult for the patients. With the gastric sleeve, because it's a long, narrow tube, it's a high-pressure system. So the foods don't go down in a relaxed stomach. It's very tight, so that can cause acid reflux, and that's a very big complaint with the gastric sleeve in the United States. And if the patient's complaining about regurgitation, they're vomiting, or food gets stuck or it's sitting right here, that's usually because they ate too fast, they didn't chew the food well, or the food was very, very spongy. I had one patient who always was vomiting after surgery, and he thought this was normal because he didn't understand what happened. So for the first, when he started to go to week 3, he was vomiting. And I said to him, what are you eating? And he said, oh, I'm doing the protein shakes. And I said, well, the protein shakes shouldn't make you vomit. But what happened was he would drink the protein shakes and then he'd run to work, or he'd be driving and drinking his protein shakes. So if a patient is multitasking or doing many different things and not sitting and focusing on their food, that can also cause stress in the esophagus. Food won't digest easily because when we're stressed, everything is constricted. When the esophagus is constricted, the food won't go down. So we need to make sure that we're sitting and enjoying our meals and not running around with food. And if they have lack of bowel movements or constipation, it's usually a sign of dehydration. So we do recommend 6 to 8 cups of water. We also have the rule of 30. So although we need them to drink as much as they can, we try to separate no drinking and eating at the same time. You need to eat, wait 30 minutes, and then drink. But make sure you're drinking all day long to help with constipation, nausea, headaches. If they're dizzy or lightheaded, the first thing we try to make sure that they're getting is enough water. The fact that the patient, if they're on narcotics, that slows down bowel movement. So some of my suggestions to get them going is, maybe they need to be walking a little bit more, because when we're walking, it's putting a little more pressure on the peristalsis, so the muscles in the body are pushing the food down. We might suggest, taking 1 or 2 tablespoons of chia seeds, put that in your protein shake, shake it up, or put it in your water and drink it. There's been so many different changes going on in their bowels, so I also recommend, if you want a probiotic, acidophilus, and this is just another slide with some other suggestions for treating constipation. I hope that this has been a helpful talk, and we'll speak a little bit more about what happens after the honeymoon phase. Many of the patients, they lose a lot of weight in the beginning. That's the easy part. What is our role after to make sure that they survive this part? This is the meal plan that I like to suggest to the patients, over the long term. It's a plate. It goes over what your diet should be comprising of. We want a diet that includes a lot of protein in the long term. We want a diet that has a lot of dark leafy green vegetables. Not all vegetables are created equal. Cucumbers are not the same as spinach, arugula. Cucumbers are mostly water-based. It's not going to give the patient that fullness factor that leafy greens will. So it's important that we educate them about the different vegetables that are out there. Some of them have never experimented with it. So we want to teach them what to look for when they're eating. Instead of doing cereal made out of corn flakes or Rice Krispies, I like to get them to do more oatmeal because it has higher fiber with chia seeds, some almonds, and some strawberries. In the United States, we take everything, we wrap it in bread. We do wraps, and sometimes my patients think a wrap or pita bread, because it's flat, has no carbs. I don't know where they got that idea from. One wrap in America is like 5 slices of bread. It's very dense, it's very gummy, there's a lot of gluten in it. Some patients are gluten sensitive after the sleeve because there's a lot of altered digestive enzymes that affect how they process food. So we try to get them off the bread and doing more platters. Thank you.
I couldn't keep